Welcome to the latest episode of Exploring Health with Cleveland Clinic London. Thank you to Cleveland Clinic Philanthropy UK for supporting this podcast. I'm your host, Kash Akhtar, a consultant orthopaedic knee surgeon. Today's episode focuses on stroke, a medical emergency that remains one of the leading causes of death and disability, but one where early recognition and fast action can make a life-changing difference. As part of Stroke Awareness Month, we're going to talk about what a stroke actually is, how to recognize the warning signs, who is most at risk, what happens in that critical early window, and what all of us can do right now to reduce the chances of a stroke happening in the first place. Joining me today is Dr Arvind Chandratheva, consultant neurologist, stroke and rehabilitation physician at Cleveland Clinic London with extensive expertise in stroke, Transient Ischaemic Attack or TIA, and neurorehabilitation. Across this episode, we'll cover what happens in the brain during a stroke, the difference between ischemic and haemorrhagic stroke, how to recognize the fast signs, who is most at risk, and what can be done to prevent stroke, and how Cleveland Clinic London supports patients across the full stroke pathway. Arvind, let's start with the basics. Yeah. What exactly is a stroke?
So great question. So a stroke is when there's interruption to the blood supply in a part of the brain, and that leads to damage in that bit of the brain. There are two main types. We call them ischemic or haemorrhagic. So the vast majority, 80%, a clot blocks the blood supply to one area, and the area that's damaged, referred to the stroke area, and 20% bleed in the brain. And that particular area that's damaged gives the deficits that the patient has.
Okay. So of that split between haemorrhagic and ischemic stroke, you say about 20% is
haemorrhagic
so
bleeding, and 80% clot.
Yeah, so there's a blockage. It's almost as if someone stood on a hose pipe and the blood can't get past it. And then that bit of brain.
Cash.
Is that thing you use, is it?
No, absolutely. I use a similar analogy. I don't use the hose pipe. I say it's like a pipe being blocked.
Yeah.
It's similar to the plumbing network in your house.
Yeah.
One of the pipes, the radiator gets blocked, radiator gets cold. And our job is to try and identify where that clot came from.
And then downstream, there will be effects of... And so I'm assuming if a different part of the brain loses its blood supply, there'll be different impact.
Absolutely. Depending on the area of which the blood supply is blocked determines the symptom. If it's an arm area, your arm may go weak. Face droop, speech disturbance. So absolutely depends on the bit that's affected.
And could you tell us where a TIA fits into this?
So essentially a TIA, some people describe it as a warning event. The T refers to transient. So it's a brief episode that is the potential warning for a stroke. It can present with the same symptoms, but they're brief. Typically minutes rather than hours.
Okay.
And classically similar to a stroke, face, arm, leg involvement or speech disturbance.
And these symptoms, when they come on, how long would they last for a TIA?
So in the textbooks, it would say less than 24 hours. But in practice, it's really less than an hour.
Okay.
The key feature is that they tend to be sudden in onset. So it's sudden onset we call it neurological symptoms. So weakness, numbness, speech disturbance, loss of vision, balance difficulties, and typically last less than an hour.
And why should people take these seriously? Because I think some people would go, well, I had a funny turn, or I'm sure you've heard lots of different phrases. Why are they things, I guess is what people refer to as a mini stroke, perhaps?
Yeah.
And why should we take those seriously?
I think that's a great question. So most people would have heard of a stroke, and everyone who's heard it wouldn't want one. Less people would have heard of a TIA, but this is a warning. So this gives us an opportunity to prevent a further stroke. It's saying this is an at-risk person. If we can try and identify what the potential source of that clot is and treat the patient appropriately, we might come on to talk about treatment, we could significantly reduce the risk of a stroke, up to 80% potential reduction in risk.
And when someone loses the blood supply or has a bleed to a certain part of the brain, what happens to that actual bit of brain tissue? Does it die? Does it wither away?
What happens to that bit of brain? So the risk is you're damaging that bit of tissue or neurons. In a stroke, we say you lose about 1 to 2 million neurons per minute. That's a hell of a lot. So ensuring that you get the blood supply back is critical. In a transient ischemic attack, what we think has happened is the clot comes and then person gets symptoms, but not enough for it to cause permanent damage. And then there's blood supply that returns and then they recover. The key bit with that is that it's viewed as a warning, not, oh, I've just had these symptoms, I don't need to see anyone about it.
And do people lose neurons with a TIA?
They can do. So there can be residual symptoms, but typically it's thought of as transient. If you do an early brain imaging, an MRI scan, for example, you can sometimes see the effects of there having been damage to that bit of tissue. And sometimes that's the clue for us that the symptoms have been related to a TIA. So an MRI early can sometimes help with diagnosis.
So it's interesting. I was thinking about this just literally while you were talking now. A TIA is almost like someone's kind of drawn something in the sand on the beach and all of a sudden a wave just come and washed it away and you're kind of back to where you were. It's almost refreshed.
Yeah, I think that's a really great description of it.
Oh, it's a shame I'll never get to use it other than now. So the public message, FAST, face, arm, speech, time, is a thing that I keep seeing on sides of buses and at bus stops. Why is that message so important?
I think they represent the commonest manifestations of an acute stroke. So in terms of a public awareness campaign, those are probably the most important symptoms to be aware of as an indicator for an acute stroke. So the F for face, as you said, A for arm, S for speech. Now, it is also important to be aware of other sudden onset neurological symptoms that might represent stroke. There's a campaign called B Fast, also including the B for acute onset balance difficulties.
Okay.
E referring to the eye, so sudden onset visual loss in one eye. And so I think whilst face, arm and speech are the most common and absolutely right for us to be aware of, it is also important to recognise that there may be other acute onset or sudden onset neurological symptoms that represent stroke.
It was interesting when you mentioned the eye thing there because I just had a flashback, almost PTSD to my vascular house job.
Bad flashback?
Yeah. I won't mention the hospital, a long time ago with old school training. You know, where the surgeons were like Sir Lancelot Spratt type. No, you boy.
I'm not that old.
Yeah. You boy, what's the bleeding time? And amaurosis fugax. And all these things were coming back to me. Yeah. If someone is having a stroke, they think they're having a stroke or someone around them is having a stroke, what should they do?
I think that's really important. And that's probably the crux of what we want to convey. I think if you have those symptoms that are sudden onset face, arm and speech, we've highlighted that trying to ensure we get the blood supply back is so critical. The key message for us would be to call 999.
Okay.
So sudden onset face, arm, speech, we would suggest call 999.
And forgive my ignorance, for any orthopods out there, F, faces and facial drooping.
Facial droop, arm weakness.
Yeah.
So drift of the arm and speech to some classically slurring of speech or difficulty getting the words out.
And so the T?
Time to act quickly.
Get on it.
Yeah.
So someone needs to get to hospital as soon as possible.
Absolutely.
Because there is this phrase, people talk about time is brain. And so exactly as you've explained so clearly and succinctly, that the earlier you can reperfuse or get the blood supply back to that bit of brain, the more chance it has of recovering and almost becoming like a TIA than a permanent loss of brain tissue.
That's absolutely right. So we are fortunate to have hyperacute stroke centres throughout the country that have capacity to deliver hyperacute interventions. And ensuring that someone presents in a timely fashion allows most chance of being able to access one of those treatments. They're often referred to clot busting or clot removal type treatments.
In trauma, we talk about the golden hour. Does that apply here? Or is there a certain time window that one would want to act in?
There are time windows. We don't have a golden hour. I think my key message would be as early as possible, which is probably true for the golden hour as well.
Yeah.
So the earlier, the better. However, there are time limitations to which we can give the hyperacute treatment. So I'm referring to treatments like thrombolysis and thrombectomy. So they are time limited. We have now newer modalities of imaging to extend that time window, but they are definitely time limited. But my key message would be earliest is best.
Okay. And we'll come back to those in due course in the conversation. Do you ever find people have waited too long for some reason? Maybe the symptoms have improved or fluctuated, or they weren't dramatic enough? Because I often see people for, orthopedic issues go, I wish you'd come sooner. Is that a thing that you see? Do you feel that people will sometimes dismiss symptoms?
It's such a good point, and we certainly forget that. Absolutely. So it might be that they didn't recognize the symptoms were related to a stroke or thought it might be something else. There might be another reason, but undoubtedly we see many people who've waited too long, so they're not in the window for an acute intervention.
I'm with you for treatment. What are the most common kind of misunderstandings that people might have about stroke symptoms?
Well, I think the first thing is the point that you quite rightly highlighted, which is those acute onset symptoms are nothing to do with the stroke, or they're mild, they'll settle down. So I think that's a really important point. I think it's the access to the acute treatments. I think there's other important points to consider as well. So I would say, look, in the UK, we have about 100,000 strokes a year. About 38,000 people die from a stroke a year. We have 1.3 million stroke survivors living at any one time. So that brings to mind a couple of things. One is this is really common. We need people to recognize those symptoms, the point you mentioned. 2, about 1 in 4 people who have a stroke will have another one in the next 5 to 10 years. We also really need to think about, even if you're out of the window for an acute intervention, we need to make sure you don't have another one. And 3, there are 1.3 to 1.4 million stroke survivors. So how do we manage those disabilities? Have you had the right input to manage all the symptoms you now have? So acute intervention, making sure you access it quickly. Prevention, to make sure you don't get another one. And disability management. I would say those are the 3 things to be aware of.
It was interesting when you were talking about, the facial droopiness, slurred speech, arm weakness. You think some people might confuse that with someone being drunk?
Absolutely. A bit of balance disturbance. And I would say what we're looking here is an acute or a sudden onset of balance disturbance in the absence of an intoxication.
Yeah.
But you're right. It could easily, the reverse way from someone being reviewed by someone, look like, could this be someone who's drunk?
So the message here is very clear. Stroke is not something to watch and wait. It's a medical emergency, and acting fast can protect brain function and save lives.
Yeah.
So let's talk about risk. What are the biggest risk factors for stroke?
I think this is really important. I think you've had podcasts talking on some of the factors, which I think are really, really important. I break it down into 3 things. 1 are things you can't do anything about. 2 are lifestyle factors. 3 are conventional vascular risk factors. So things you can't do anything about: age, we're all getting older. Age is a risk factor. And then genetic factors. Can't change your genes. Ethnic variations, geographic variations. Lifestyle factors, and I think that is critical. What are the things I can do to promote the best vascular lifestyle for myself? What have we got? A rising obesity epidemic. Diet is a critical factor. Sleep hygiene, obstructive sleep apnea, a type of sleep disturbance that increases risk. Smoking, alcohol, recreational drug use, exercise. So it's a huge range within our control. And I'm sure you'll talk about those risk factors in other podcasts that you do.
Yeah.
And then conventional vascular risk factors: hypertension, diabetes, hypercholesterolemia. And the interesting thing about a lot of those things is that you don't really feel you've got them. It's not like chest pain, arm pain, knee pain. I've got knee pain, I'm going to go and see Kash. I don't feel necessarily that I've got symptoms that make me think I've got hypertension. In fact, the tablets make me feel worse.
Yeah.
So I think for me, 2 crucial things. 1, identification of them. 2, compliance with treatment. How many people do we put on antihypertensives, maybe lipid-lowering therapies, diabetic medications? I really don't like these. Why am I taking them? And so I think that's really important as well.
I'm with you. And the other thing, I guess, would be something like atrial fibrillation, abnormal heart rhythms. They seem to be associated with stroke, don't they? Can you explain why that might come into play?
Yeah. So when we're thinking about why a stroke occurs, we're looking for the source of the clot. And coming back to your analogy right at the beginning, the hose pipe, my analogy, pipes in a boiler system and radiators in the house, what we're trying to find out is where did that clot come from? The way we break it down is it a problem in the large pipes, furring of the vessels? And that we think about things like hypertension, diabetes, all these lifestyle...
Smoking, cholesterol.
Absolutely, we think about those things. Then the next thing is to look at the boiler or the heart, where all the pipes come out of. And what we're looking at is both the structure of the heart. Are there any abnormality in the valves and things like that? But one of the main cardiac causes for clot that increases the risk of stroke is this rhythm disturbance, this abnormal rhythm called atrial fibrillation or paroxysmal atrial fibrillation, which means it comes and goes. We've got this watch on. We have different devices that can now detect it. But what atrial fibrillation does is it increases the risk of clots, and those clots pick up and can cause a stroke. The reason it's so important for us to detect it is that we have treatments that reduce the risk of clot from atrial fibrillation by 2/3. Those are called anticoagulants.
Blood thinners. And it's interesting because these risk factors, as you said, are silent risk factors. So people don't know they have them, and they won't know they're at risk necessarily until something happens. And that can be in the brain, in the heart, so many things.
Yeah, absolutely.
One thing that is increasingly interesting is the fact that strokes predominantly affect older people. But do you often see them in younger adults?
Absolutely. So whilst stroke is commonest with increasing age, because age is a risk factor, it's absolutely increasing in the young population. And
So
we're
you're
seeing
seeing
20s, 30s, 40s, absolutely. So one of my PhD students has just finished her PhD and it was all on young stroke, the risk factors and the outcomes of young stroke. If we think about some of the risk factors, one of the main ones we talked about was obesity, which we know is rising.
Yeah. I see you keep looking at my hot chocolate. I might just move it. It's full fat as well, organic.
Heavy hot chocolate.
I might move,
Hide out of my way.
I'm moving out of the way.
No, but there's got to be balance in life, Kash.
Yeah.
But you're absolutely right. But what's interesting is that young stroke risk factors are often similar to older strokes.
Okay, because I was wondering if it was something different.
Well, it probably falls into two groups. So there are the young stroke population who have early hypertension, hypercholesterolemia, obesity, diet, lifestyle factors. And there is the young stroke population who don't have any risk factors at all. To be honest, I don't really like the term young stroke and old stroke. I think it's not helpful. I refer to it as stroke with risk factors and stroke without risk factors.
Okay.
Because you can have young people with lots of risk factors, unhealthy lifestyle, obese, but you can have an older person who's super fit, still going to the gym all the time, and don't have any risk factors. So it's much more helpful to say stroke with risk factors, stroke without.
Rather than age.
Absolutely.
And do recreational drugs, can they cause stroke?
Absolutely, yeah. In fact, we would see that quite commonly. The challenge for us is people might not always be forthcoming about it.
Yeah.
And there are many mechanisms by which recreational drugs can cause stroke. It can be from the drug itself. For example, cocaine would be a common one.
Yeah.
Its effect on the blood vessels. It can cause inflammation of the blood vessels. It can cause a narrowing of the blood vessels. It can cause a spasm of the blood vessels. It can cause a rise in blood pressure. But also, what we don't always know is what are the drugs cut with, what are they mixed with, and what can be the effect of that, the substances that the drugs are mixed with.
One of the most important public health messages during Stroke Awareness Month is know your numbers. So if I was to ask you which numbers matter most?
That's a great way to think about it, actually. So I guess we know our height and weight and things like that. But so I guess in stroke, one of the things we think about, we think about what's our blood pressure.
Yeah.
Which is a really easy thing to get tested, right?
Yeah.
You can get anywhere. They're cheap as chips to get a blood pressure monitor. what's my lipid levels? Okay, cholesterol, LDL, they're different types of liver level. What are they? And so I would say those are probably, and weight probably would be, or body mass index would be the things I would say are useful numbers to know about.
And I guess you'd probably add in HbA1c.
Diabetes, yeah, HbA1c.
For diabetes, just
and
know
pre-diabetes, as you had in your last podcast.
Yeah, I only know these things. We talked about it recently.
This is like education.
Yeah, for sure. And this is how I get my CPD, lipoprotein A. And then I imagine saying that to an orthopod. Is there a particular risk factor which really worries you clinically because it's either really common or underdiagnosed or really dangerous?
I guess most focus would be around blood pressure.
Okay.
I think there's a cumulative effect to having more than one, of course, increases risk. I think the key bit is to identify it. But then the aspect I worry about most is then compliance with treatment and ongoing monitoring. This is not something you just say, oh, I've been diagnosed with hypertension, I'm going to have this tablet, see you later. The ongoing monitoring is really important as well because it can change over a lifetime.
For sure. Can stroke risk genuinely be reduced or even significantly reversed if the right action is taken early enough?
That is critically important. So can I give you the example of TIA?
Love it, please.
So we talked about early mini stroke. So the risk of a further stroke at 7 days is 10%. 1 in 10 will go on to have a major stroke. Okay. And then at about 90 days, it's 12 to 15%. And then at 10 years, it's about 20%. Okay.
1 in 5.
So 1 in 5 are going to get another stroke at 10 years. And that's most early. What we know is that if you see the right people, have the right tests, and start the right treatment, which is a combination of things that we've touched on already, which is manage the lifestyle factors, blood thinning, and looking at your blood pressure, cholesterol, diabetes, you reduce the risk of recurrent stroke by 80%, which is a massive implication and massive incentive to try and see someone, start the right treatment, and identify the risk factors.
So much of stroke prevention starts before any symptoms ever happen. So if we can identify these silent risk factors and take them seriously, then we can have a huge impact on people's health and how long they live and the quality of their life.
I think that's quality of life, particularly recurrent stroke, massively.
Just out of interest, for someone who's an adult having a stroke, what are the chances that stroke might actually kill them?
Or just to give you the example, as a whole in the UK, 100,000 people getting a stroke, 38,000 people die of a stroke a year.
Gosh.
And that's not from the 100,000, that's from the whole population.
I'm with you.
Stroke.
So if we talk about prevention, I'll move on to that. So we've talked about blood pressure, so control that. Pre-diabetes, diabetes, intervene with that. High cholesterol, it can be treated in various ways. If you smoke, stop. If you're taking recreational drugs, don't. If you're overweight, find a way to reduce your weight. I don't mean that so flippantly or directly. There are people who can help you, and there are ways now, better than ever, to reduce your BMI. And then you've mentioned what we call blood thinners, antiplatelet therapy. Tell me about that, where that fits in all this.
So we started right at the beginning saying this was a clot in 80% of people, of course, that blocked a blood vessel. So then it seems intuitive that the main treatment, or one of the main treatments, would be to give something to thin the blood. And there are different mechanisms by which the blood clots. And one of the main mechanisms, this thing called the platelets, so a clotting substance that causes the blood to stick. And what we tend to give is drugs called anti-platelets to stop the platelets sticking. And there are different ones. Most people would have heard of drugs like aspirin, and there are aspirin-like drugs that we give now.
Okay, so that's for the infarcts, the clot that has blocked your pipe. You mentioned earlier the alternative of that, the hemorrhagic stroke. So they're people who've bled. And so for those people, you're not going to give them a blood thinner. Is there any way to try and prevent that, particularly if someone's had a TIA and you think that's the cause?
So if we think a stroke has been due to a bleed, then generally we would avoid drugs to thin the blood. You're absolutely right. And then the first step is to identify why did they bleed. The two commonest causes of bleeding in the brain in the UK are one, hypertension. So treat the hypertension. And 2, there's a condition called, it's a long name, cerebral amyloid angiopathy. And again, the main treatment for that is managing the blood pressure, avoiding things that's in the blood.
Yeah.
So you're getting a theme here that managing the blood pressure is critically important across the board.
I'm with you. The other thing that I recall seeing quite a lot as a vascular house officer in that traumatic period was what we call carotid artery disease.
Yeah.
Could you talk about that and just explain to everyone listening or watching what that is and how it can be treated?
So that's really important. So again, we've talked about the heart and the boiler and the AF, and then we talked about the pipes. So you've essentially got 4 main blood vessels or pipes that supply the brain. You've got 2 at the front, 2 at the back. The 2 at the front are called the carotids, left and the right, and the 2 at the back are called vertebrals. A common cause of stroke is narrowing of the front pipes, the carotid arteries. And there is management for people who have narrowing of their carotids causing their stroke. And the colleagues who we work with very closely in management of the carotids are called vascular surgeons. So surgeons like yourself.
Yeah.
So between us, we would make a management plan.
Yeah. So carotid Dopplers, is that how you'd go about an ultrasound scan of the neck? Is that how one would go about diagnosing it, or has that moved on since those days?
Yeah, so since the early times.
The dark ages.
So Doppler, to be fair, Doppler is still a mainstay. It's an excellent image for the carotids. But now what we have in our armory is a range of imaging to help better define what the whole tree looks like from the top of the heart to the top of the head. So we can use MRI, we call MRI angiogram, and we can use CT angiogram. And within those, we have really sophisticated imaging to look at how the vessel wall looks, to look at narrowing. So we can really get a much better picture of where this narrowing is, the degree of furring through the whole vascular tree.
Okay. What we're talking about here is primary prevention, stopping it from happening in the first place. Then there's this concept of secondary prevention. Could you just explain what that is and how that fits in?
Yeah, both are crucially important. Primary prevention is when there's never been an event at all. So you've never had a stroke, you've never had a heart attack, and you've just identified risk factors and you're trying to treat them. Secondary prevention is when you're really trying to make an impact. So it means there's been an event of some kind. You've had a TIA, the mini stroke, you've had a stroke, or you've had a heart attack. And what you really want to do is to prevent another one. And that's what we refer to as secondary prevention. And that's what I was talking about in terms of that 80% reduction in risk by looking at the lifestyle and the other risk factors.
So you'd essentially go back to all the causes of the primary prevention, but it's just applying it after the event if it's not been picked up before.
Absolutely. And often it would be the time that these risk factors are picked up.
Yeah.
They may not have been identified in the past.
Yeah, because if someone's had a stroke the first time, they've come to you. Once you've got through the acute treatment, that's when you would then do all the workup. And a lot of the time, they won't have had these tests before.
After that hyperacute phase, we're immediately thinking about what are the causes, what are the risk factors, how do we best treat this individual?
A topic that keeps coming up in this podcast again and again is the role of sleep, the role of nutrition. I'm just trying to understand how it fits in here, because to a lot of people listening, they sound like quite broad things, be healthy, make sure you sleep properly. I'm just trying to work out how that fits into causing stroke prevention, any tips or tricks for people.
It's a really tricky question because we don't have lots of what we call randomized control trials where we've had a whole population and we split them in half and we give half one diet and half another diet. It's really hard to do those kind of studies, or even deprive half of sleep and half not. What we're looking at is anecdotal studies where people, by nature of their job or profession, have been sleep deprived or have had certain diets, looking at geographies. But if I speak in broad terms about advice from national guidance in terms of 1, sleep, and then 2, diet, and then maybe 3, exercise, which are the sort of big groups. So sleep, I'm sure you will have people who are more experienced in talking about sleep. But what we're increasingly recognizing is sleep is restorative in every way. You just feel better when you wake up. So you can simply, by that analogy, think it must be having restorative effects to us. 2, we know there are abnormal sleep patterns which increase the risk of stroke. So 1, I touched on, was obstructive sleep apnea, a type of snoring. You don't feel refreshed when you wake up in the morning, typically linked to obesity. Diet. There's lots of discussion about Mediterranean diets, low-carb diets, and some of that is slightly related to whether there is diabetes or not and management of that. But I guess that's what we would be talking about. And then exercise, we believe, both in hemorrhagic and ischemic stroke, is not only good for recovery, holistically good for your recovery, but also in prevention. But I think it's definitely an area we need to understand better. We need to understand better how to guide people on what to do. My experience post-stroke is that often people are a bit more cautious first in terms of exercise. It's often a very receptive time to make changes because a lot of things in relation to diet, sleep, and exercise as a habit, you've been doing it all your life. So it's suddenly, how do you interact that behavioral change? So what we're trying to do in stroke in our area is think, how do we really get people self-managing a little bit more to direct some of those changes that are going to be sustainable in the long term?
And it's interesting because when you see people, I'm just realizing that this is probably quite likely the biggest life event they've ever had.
Yeah.
And it's almost the time where people are like, right, I'm changing everything. I'm stopping smoking. I'm going on that diet. I'm joining the gym. I mean, you must see people at a huge turning point in their lives.
Yeah, it's an incredible opportunity to have that moment to try and impact change. And there are not many situations like that where you could really be part of supporting someone making a difference for the rest of their life. But it's a two-way process. We can give the information and then someone's got to be motivated and receptive to do it. And we have to encourage that sustainable change. It's easier to make short-term changes, harder to keep long-term changes.
Understood. But when we talk about high blood pressure, diabetes, cholesterol, the fact is that smoking, body weight, BMI, prevention is not vague. It's practical, it's measurable, and often highly effective when people know their risk and act early. Let's move on to treatment. If someone is having a suspected stroke, could you talk me through the pathway of what happens when they arrive in a stroke unit, what treatments are given, what investigations are done, in what order, and how we would kind of proceed along that as if we were kind of following someone?
So if I could take the ideal pathway, it would be 999, ambulance crew, come into a hyperacute stroke unit, be assessed by a stroke team, which is often stroke nurses and doctors, and then decide whether there is an opportunity to give clot-busting treatment. Now, that's a time-dependent treatment, so it depends where in the timeline from onset of symptoms. There will then be brain imaging to determine if it was a clot or a bleed.
And that would be an MRI scan?
Typically a CT scan straight away. And we'll decide if it's a clot or a bleed.
With or without contrast in that stage?
It would depend. So in some centres, it would be without contrast. In a lot of centres, it would be with contrast and to look at the blood vessels as well. So you typically do a CT scan of the head, and then you'd want to have a look at the blood vessels at the same time as well. Is there a clot in the blood vessels? So you'd have a CT head, what we call a CT angiogram, and then if it's a clot, decide whether we give something called thrombolysis, a medication to try and bust the clot, or refer to one of our interventional neuroradiology colleagues, another clinician who tries and removes the clot with a procedure.
Yeah. These podcasts are really interesting for me because I get flashbacks to different moments in my career. And right now I'm thinking of being an A&E SHO, emergency department junior doctor at St Mary's in early 2000s, and having to give someone streptokinase for a heart attack and trying to thrombolyse. And so similarly, you're talking about someone giving an intravenous drip over a period of hours to thin the blood to try and... That's not going to dissolve the clot that's there necessarily.
That's the idea. So it is absolutely the idea. So it's not over hours. Right. So we can now give We're moving to drugs that can be given over minutes rather than an hour. And hopefully nationally we'll move towards the drug that will get, and the idea it is lysing the clot. We call it thrombolysis.
Yeah. So you're talking about clot busting. It is actively stopping that. But dissolving that clot, trying to get the blood flow back to the brain. And if someone's had the infarct, the lack of blood to the brain, then how does that get treated?
So if the person is eligible for the thrombolysis or the thrombectomy, which is where we go in and remove the clot, then after that occurs, we would follow up the next day with a follow-up scan. And the follow-up scan and the clinical assessment would determine what the residual, what we call deficit or impairments or injury are, both on the scan, radiologically, and by us assessing them.
So if we think of it very broadly speaking, there's a bleed, there's a clot, we're going to bust that clot, or there's a bleed. And so how would you treat the hemorrhagic stroke?
So I would say similarly for the clot, hemorrhagic, time is really important. And we manage them with that same fast pathway. Mortality is really high following a hemorrhagic stroke, about 40% death at a month. So it's really high. And what's a massive game changer to that is being seen early by the right team, making sure we aggressively reduce blood pressure, make sure we prevent and early identify any signs of swelling or pressure in the brain, and then make sure we treat infections, clots in the legs, and really make sure there are no complications.
Okay. When we talk about removing clots, the thrombectomy, how's that done?
So that's typically a procedure done by our radiology colleagues. And what they will do is, often it would be a general anaesthetic, and then we'll go in through the groin, put a needle through the groin, pass a wire right up into the brain, identify the clot using dye, and then there are devices to try and remove the clot.
And physically pull it out.
Physically pull it out, yeah, absolutely right.
Awesome. How important is multidisciplinary approach in stroke care?
We can't do it without it. This is amongst, I think we were talking about this first bit, which is the hyperacute treatment, and we've touched on prevention, and now this bit, you touched on it. Now they've got the impairments despite all that treatment that we've done at the beginning. What do we do now? And that's critical. So we have a team of nurses, occupational therapists, physiotherapists, speech and language therapists, psychologists and doctors. We work really closely across the board. And it depends on what the individual has. As we said before, it depends where the clot is. So is it weakness? Is it numbness? Is it walking? Is it bladder? Is it bowel? Is it cognitive? Is it mood? Is it anxiety? We broadly differentiate it into motor and non-motor symptoms. And what I think is really important to mention today is there's a lot of hidden disabilities as a result of stroke. So some people can look really well after a stroke, but they can have a lot of other additional, what we call non-motor symptoms. So mood, anxiety, pain, difficulty adjusting back to life, difficulty with return to work. And having those identified and explored early, being signposted to the right people is really important.
And you talk about mood, there are certain, depending on which part of the brain is affected, that can affect personality, memory, mental health.
Massively important. I wouldn't even say depending on the area of the brain, actually. And what we're increasingly recognizing is sometimes it's irrespective of the area of the brain that these non-motor symptoms are really prevalent. When we looked at young stroke patients who were, inverted commas, physically okay after their stroke, there were really high rates of mood and anxiety, up to 50%. Really high rates of non-specific pain, really high rates of sphincter difficulties, what I mean by bowel and bladder difficulties, really high rates of relationship difficulties afterwards. So the psychology for the cognitive mood, anxiety are really important as well. So that's part of the whole MDT approach to try and holistically manage someone after a stroke.
One of the strengths of Cleveland Clinic London, one of the things I've enjoyed the most is the integrated pathway and the connection between specialties, just having to have conversations with people who are really at the top of their game. Where does the Cleveland Clinic London stroke management, does it fit in the acute phase? Does it fit in the recovery rehabilitative phase?
So the hyperacute phase in the UK is managed through the hyperacute stroke centres.
Via 999.
Via 999. After that is where Cleveland Clinic London would fit in, because you've got a team of clinicians who, I mentioned, vascular surgeons, neurologists, stroke physicians, orthopaedic surgeons, believe it or not, for shoulders. And so you've got a range of people who commonly work together, cardiologists. Additional to that, you've got a large neurorehab unit. You've got access to excellent gym equipment to try and build that intensity, because what you want is intensity of rehabilitation in that early phase.
That's that huge gym on the second floor.
It's a huge gym on the thing with all the robotics.
Amazing. Like, I've seen a treadmill with like a robot exoskeleton.
Absolutely.
What does that do exactly?
So what we're trying to do is have different ways of moving the joints, introducing that intensity of rehabilitation for people who simply can't do it on their own. So it's trying to start those early pathways to hopefully build up to them doing it on their own.
Because it looks like you would strap someone to this robot exoskeleton, stand them on a treadmill, there's some sort of screen showing them what they're doing, and then it helps them walk. Yeah.
So there's, as you say, exoskeleton type support, along with prompting, along with, this is not something you can just do on your own.
Yeah.
You can't just go to a gym and have this kind of thing. You need experienced therapy clinicians to guide you appropriately using the equipment. I think that's really critical. You need the people who are accessing the movement in the right way to prevent injury. What you don't want is to get an injury in this early phase. What you do want is in the right kind of intensity.
Yeah. I've seen kind of recumbent bicycle type things where you strap someone in and it gets their legs cycling.
100%, yeah.
Something with gloves.
Yeah.
Tell me about that.
That's really, so there are, one of the areas, the A bit, the arm weakness.
Yeah.
That's really disabling, really frustrating. And there are the complications associated with that. The pain, the stiffness, the weakness. And one of the critical steps to recovery of that is starting movement. And what you want is intensity, repetition, and the right kind of movements. And what these gloves do is electronically assist with the right movements, encourage repetitive movements, and support in the right kind of movement. So we're very fortunate to have access to these.
So the patients put their hands in?
There are different types. One is you can put your hands in, guided by video, stimulated, supported by robotics. Yeah.
There's also a kind of a full working kitchen.
There's a full working kitchen, absolutely.
Yeah. Although it was interesting because
that's not just for orthopedic snacks.
I've seen it on a tour, and I did think that if using a washing machine was a test, I'd fail. I wouldn't get discharged. But no, it is amazing the setup, and there's a whole a host of people there. So that is really, and there's a lot of neurorehabilitation offering, isn't there, at Cleveland? There's a fair number of beds set aside for it.
Absolutely. So the whole unit has a 42-bedded. It was set up for a 42-bedded neurorehabilitation unit. There's access to the big gym. There's a smaller gym nearby. But the most important aspect to that is that the appropriate neurotherapy team attached to that, neuronursing team attached to that. You want people who are knowing exactly what you need at that moment in time.
Yeah.
And managing stroke patients is important because everyone is slightly different. So one cannot apply the same program for each patient.
It has to be bespoke in each time.
Absolutely.
Because there's so many, it's almost like an a la carte, a bit of this, a bit of that, a bit
100%.
of that, focused to each deficiency.
And one of the biggest impairments after stroke is fatigue. Now, people find that hard to realize because they can't see it. Even if you show them on a scan, it's much easier if you've had a knee injury. You can see it, you can't walk, you feel knackered, and that's just with a knee injury. Imagine if you've had a brain injury. And I think people don't recognize the impact of both physical and cognitive fatigue.
So a lot of the thing about the full pathway model at Cleveland Clinic then is a lot of it comes into preventing the next event and supporting recovery, where all these different teams fit in across, so you get care across the whole pathway. Cool. Before we close, what are the most important things that you would want anyone watching or listening to remember from today?
I think I would like people to most remember the key signs, to remember time is brain, to remember that there are strategies that we can do to prevent injury in the hyperacute phase, and then the importance of the lifestyle and vascular risk factors that contribute to recurrent stroke. And finally, that if you have had a stroke, there are teams that are there interested and willing to support your recovery.
So today we've talked about what stroke is, why every minute matters, how to recognize the warning signs, who is most at risk, and what can be done to prevent it. The key messages are simple. Know the fast signs, know your numbers, control your risk factors, and if stroke is suspected, act immediately because you could save a life. Thank you to Dr. Arvind Chandratheva for joining us and for sharing your expertise on stroke, urgent treatment and prevention, and thank you for giving us an insight into the expertise and services available here at Cleveland Clinic London, from acute stroke assessment through to longer-term prevention and rehabilitation. I'd encourage everyone watching or listening to share this episode, learn the fast signs, and seek medical advice early if they're worried about stroke risk or possible warning symptoms, because with stroke, rapid action can change everything. You've been listening to Exploring Health with Cleveland Clinic London. I've been your host, Kash Akhtar. If you'd like to learn more, you'll find links and resources in the show notes and on the Cleveland Clinic London website. And if you found this episode helpful, please subscribe, leave a review, and share it with someone who needs to hear it. Remember, informed health is empowered health. Until next time.